Okay, hello everybody. My name is Arno van Leenders from Erasmus Medical Center in Rotterdam, the Netherlands. I welcome you at this ISUP webinar entitled Prostate Cancer Grading Beyond Gleason Score. Okay, see what works. Yeah. The Gleason score has been a prostate cancer grading system for more than half a century now. And the Gleason grading system is unique. It's unique for two reasons. At first, it takes into account tumor heterogeneity by adding separate Gleason grades. And second, it's only based on the assessment of tumor growth patterns. The Gleason grading system was originally developed in the 1960s, but has since then undergone several modifications. The most important modification was the one in 2005. A second minor modification took place in 2014, and the latest modification dates from September 2019. What was the rationale for the Gleason score modifications? Well, first we have to realize that prostate cancer presented as a different disease in Gleason's days. It was often discovered at the transurethral resections of the prostate for BPH, or at one or two targeted biopsies from an abnormal prostate. At that time, no PSA testing was performed yet, and immunohistochemical stainings were not available to pathologists. In contrast, in current daily practice, men get PSA tests and receive often more than 10 systematic and targeted biopsies, leading to detection of smaller tumors in an earlier stage. Furthermore, pathologists widely use immunohistochemistry for distinction of prostate cancer from its mimickers. For instance, here is an example of a TURP specimen with a glandular lesion that Gleason would probably have called Gleason score 2 + 1 = 3 prostate cancer. But if we do immunostaining, we can appreciate basal cells are present. In this case, the basal cells express S100, which is characteristic for sclerosing adenosis. The 2005 ISUP prostate cancer meeting set the base for current prostate cancer grading, while in 2014 some minor modifications were included. The most important of these minor modifications were that small cribriform glands should all be assigned a Gleason pattern 4 and not 3, and that glomerular pattern should be graded as pattern 4. One of the consequences of the grading modifications is that 1/3 of the old Gleason score 6 tumors is now upgraded to Gleason score 7 or even higher. This makes that Gleason score 6 now only well-delineated round to oval tumor glands are accepted. In this figure, we can see the typical impact of Gleason score or grade groups on clinical outcome when Gleason score 6 at prostatectomy specimens is associated with excellent outcome, and about half of men with Gleason score 8 to 10, that is grade group 4 and 5, will develop metastasis. So now let us look at the grade groups in more detail. As said, men with grade group 1 prostate cancer at prostatectomy have excellent outcome. In a study from our group, among 1,100 radical prostatectomy specimens, no man died of prostate cancer or developed metastasis. In a much larger series of more than 14,000 prostatectomy specimens from Johns Hopkins, likewise, no man with Gleason score 6 developed metastasis. Because of this excellent outcome, urologists frequently ask why pathologists still call Gleason score 6 cancer and not, for instance, adenoma. This would make it easier for urologists to explain to patients with Gleason score 6 on biopsy that they don't have to be treated and can be put on active surveillance safely. In answering that question, it is important to realize that Gleason score 6 at the prostatectomy specimen is not the same as the Gleason score 6 at biopsy. All studies showing that men with Gleason score 6 did not develop metastasis were performed on prostatectomy specimens. So, The entire specimen was available for microscopic evaluation and the tumor was entirely removed. On the other hand, biopsies only sample about 0.1 to 1% of the entire prostate volume, so higher grade tumor areas can easily be missed due to sampling artifact, and in biopsies the patient has not been treated yet. This is also reflected in surveillance studies, which show that 2% of men with Gleason score 6 on biopsy will develop metastasis and die of their disease. It is, however, important to know that about 10% of men with Gleason score 6 at prostatectomy will develop biochemical recurrence after operation, clearly showing that biochemical recurrence is not the same as metastasis. Personally, I think that pathologists can really improve clinical management of men with grade group 2, that is Gleason score 3 plus 4 or 7 disease. As you can see, clinical outcome of these men is variable. What has become clear in the last 5 years is that pathologists can provide far more detail on risk stratification in this large subgroup of patients and that they really affect clinical decision making. So let's have a closer look on men with grade group 2 prostate cancer. According to the 2005 ISUP grading rules, biopsy Gleason score is composed of the most predominant and the highest grade. So 55% Gleason pattern 3 and 45 pattern 4 is score 7, but 99 pattern 3 and 1% pattern 4 is also 7. By instinct, the first Gleason score 7 will of course be more aggressive than the second one. And that was nicely shown by the Martini Clinic in Hamburg. In a set of more than 12,000 radical prostatectomies, they studied the impact of percentage Gleason pattern 4. Typically, standard biochemical recurrence-free survival curves go like this. However, if they took percentage pattern 4 into account, the curves looked like this. We can see now that biochemical recurrence rates increment with increasing percentage of Gleason pattern 4 in the radical prostatectomy series. So, percentage Gleason pattern 4 is an additional pathological parameter that can support risk stratification of grade group 2 prostate cancer patients. And therefore, the latest 2019 ISUP rules recommend to report Gleason pattern 4 percentage in men with Gleason score 7 prostate cancer. Another way of looking at Gleason scores is this nice painting by Mark Rothko. As we all know, black is not a real color, however, but a mixture of all different kinds of colors. Similarly, Gleason pattern 4 is not a one growth pattern, but a mixture of growth patterns that all have in common that tumor cells show luminal differentiation but are not able anymore to form well-delineated round to oval glands. Although tumor growth patterns have not been specified in all the literature, recent studies show that cribiform pattern is associated with worse outcome in Gleason score 7 prostate cancer patients, as clearly shown in this figure. And it does not only account for radical prostatectomy specimens. In a study of more than 1,000 diagnostic biopsies with more than 13 years follow-up, we found that presence of cribiform pattern was associated with almost 6-fold higher risk of development of metastasis in grade group 2 patients. But we can also look at this in another way. We now know that grade group 2 men with cribiform pattern have much worse outcome than those without. But how do grade group patients without cribiform pattern compare to grade group 1 men? Well, as you can see, there was no statistically significant difference between both groups in this study, both having less than 5% metastasis. This means that grade group 2 men without cribiform carcinoma also have excellent outcome. Both percentage Gleason pattern 4 and presence of cribiform growth have added value in risk stratification of Gleason score 7. But the question is raising whether they are both independent factors or mutually related. In the previous biopsy study, we found both are indeed strongly related. As you can see here, biopsy grade group 2 men with less than 10% Gleason pattern 4 had cribriform architecture in 6% of cases. But the frequency of cribriform pattern increased to 44% in grade group 2 biopsies with more than 25% Gleason pattern 4. And although not shown in this slide, presence of cribriform growth outperformed percentage Gleason pattern 4 in predicting clinical outcome. Cribriform growth is an independent predictive parameter in Gleason score 7 patients. But what about men with Gleason score 8 cancer? According to the 2014 ISUP consensus conference, Gleason score 8 tumors are now all referred to as grade group 4. One of the criticisms of the grade group system, however, is that information on the underlying Gleason scores in grade group 4 is lost. It can be Gleason score 3 plus 5, 4 plus 4, or 5 plus 3. But can relevant subgroups be distinguished among these high-risk patients? Several groups have studied whether clinical outcome of Gleason score 3 plus 5, 4 plus 4, and 5 plus 3 is indeed similar, but the results are contradictory. One group finds that 3 plus 5 do better, another that there are no differences, yet another again that 5 plus 3 do worse, and to complete the story, we found that 4 plus 4 did worst. Apart from differences in clinical endpoint, what is the cause of these different outcomes? It is important to realize that Gleason score 8 tumors are the most heterogeneous we have. These 5 examples all show how Gleason score 8 biopsies can have a large range of Gleason patterns 3, 4, and 5 percentages. And similar to Gleason pattern 4, pattern 5 also includes a variety of growth patterns referred to as single cells, chords, solid fields, and presence of chlamydomnecrosis. And on top of that, cribriform growth can be present or not. This huge heterogeneity probably underlies the very different outcomes in grade group 4 studies up to now. What is of interest is that 2 studies also looked at the impact of cribriform pattern in grade group 4 patients, and they had quite similar results, namely that men with cribriform growth had much higher chance of dying of their disease than those without. And the other way round, Gleason score 8 men without cribriform pattern actually had quite good outcome with less than 10% disease-specific death. So, summarizing the results up to now, cribriform pattern has independent predictive value in prostate cancer grade groups. Cribriform pattern is related to but outperforms percentage Gleason pattern 4, and men with grade group 2 disease without cribriform pattern have comparable disease-specific survival rates as to men with grade group 1. Therefore, the ISUP recommends to report on the presence of cribriform carcinoma in all cancers. There are still several questions. We have shown the independent predictive value of cribriform pattern, but what about its distinction from cribriform intraductal carcinoma? And how should we report cribriform pattern? What is its differential diagnosis? And finally, why is cribriform carcinoma that aggressive? I will now give an answer to all these questions. Intraductal carcinoma of the prostate is defined as a malignant epithelial proliferation in the distended pre-existent prostate glands with a basal cell layer. It can have a cribriform or solid architecture, either with or without chlamydomnecrosis. Furthermore, pin-like structures with extreme nuclear atypia are also considered as intraductal carcinoma. Invasive cribriform pattern 4 can look very similar to cribriform intraductal carcinoma, with the only difference being that intraductal cribriform carcinoma has basal cells and invasive cribriform carcinoma has not. To distinguish both, basal cell immunochemistry is required in most cases, but even then classification is not always clear. For instance, it's generally accepted that some high-grade pin glands lack a basal cell layer, probably due to sampling artifacts. Intraductal carcinoma occurs in distended pre-existent glands, making the chance of sampling artifacts and basal cell staining even larger. Look at the pictures on top, with two cribriform growth patterns aside, the left one with and the right one without basal cells. Is this a combination of intraductal carcinoma and invasive cribriform carcinoma then? If both were pin glands, would you accept the right gland having no basal cells as being compatible with pin? Well, I would. So in this figure, probably both are intraductal carcinoma with basal cell sampling artifact occurring on the right side. The other way around, in the lower panel, some clearly invasive structures can have sporadic basal cells, and it is not clear whether to classify those as invasive or intraductal. Taken together, most studies on the relevance of either invasive cribriform carcinoma or intraductal carcinoma do not state if and how they distinguished invasive cribriform and intraductal carcinoma. In a study we did, it was shown that both had added clinical value and simply labeled the cases as invasive cribriform and/or intraductal carcinoma. In the 2019 ISUP consensus conference aimed to clarify on this issue. It was recognized that rarely on biopsies, intraductal carcinoma can be identified without invasive tumor glands. These cases are almost always associated with unsampled high-grade invasive cancer in the prostate. If one encounters such a case of IDC without invasive cancer in a biopsy, it should be reported as pure intraductal carcinoma, and a note should be added on its clinical relevance. In most cases, however, IDC is intermixed with clearly invasive cancer. In those cases, it can just be graded as if being invasive cancer. So, a case of Gleason's pattern 3 glands and cribriform IDC can be reported as grade group 2 now. The advantage of this is that urologists will not automatically consider these patients to have low-grade disease and to be eligible for active surveillance. And finally, because of their association with adverse clinical outcome, presence or absence of invasive cribriform and/or intraductal carcinoma should be reported in all cases. Then I briefly want to discuss the differential diagnosis of cribriform prostate cancer. The most important diagnoses to be considered are ductal type adenocarcinoma, high-grade PIN, normal central zone, and clear cell cribriform hyperplasia. Cribriform carcinoma can closely mimic ductal type adenocarcinoma. In ductal type adenocarcinoma, lumina are, however, slit-like and not punched out. The tumor cells are pseudostratified and papillary growth may be present. The distinction of cribriform carcinoma and ductal type adenocarcinoma has minimal clinical impact, as both are associated with more aggressive disease and are graded as Gleason pattern 4. The distinction of intraductal carcinoma and cribriform high-grade PIN is more arbitrary. Cribriform high-grade PIN occurs in non-dilated pre-existent glands, which is in contrast to intraductal carcinoma. Cribriform high-grade PIN is not common, and at this moment it is not entirely clear whether this should be regarded as an indolent form of PIN or the tip of the iceberg of IDC. The Hopkins group has shown that loss of P10 in these lesions favors a diagnosis of IDC, while intact P10 would be more compatible with PIN. Furthermore, last year's atypical intraductal proliferations have been recognized, which fall short for a definite diagnosis of IDC. The clinical relevance of these lesions is not evident yet, but some reports suggest they are also associated with more aggressive disease. If I encounter such a case, I comment that intraductal carcinoma cannot be excluded, raising awareness to the clinicians that a tumor could be more aggressive. Not all cribriform lesions are malignant, however. We should be aware that normal central zone, which is situated at the craniodorsal side of the prostate, can show some bridging and small cribriform structures, as in this case. Finally, clear cell cribriform hyperplasia is a benign lesion which by definition has a cribriform architecture. Clear cell cribriform hyperplasia is rare and found in the transitional zone. In contrast to cribriform intraductal carcinoma, it lacks nuclear atypia and has a prominent basal cell layer, which can be recognized already at low magnification, such as in this case. It is well recognized that invasive cribriform and intraductal carcinoma are associated with aggressive disease behavior. And the question is therefore raised whether there exists a molecular background for that dismal behavior. In most molecular studies, pathologists encircle a representative tumor area on the glass slide, as in this case. After which the researcher performs molecular analysis on the entire area as a kind of black box. But information on underlying growth patterns is lost and not taken into account. Some recent studies have compared prostate cancer with cribriform growth to tumors without cribriform pattern, and these studies typically found that samples with cribriform morphology have increased levels of genomic instability. For instance, loss of PTEN and amplification of c-MYC are more frequently found in cribriform carcinoma than in non-cribriform cancers. Therefore, the hypothesis is that cribriform architecture is a morphological substrate of increased genomic instability in prostate cancer, which could well explain its association with more aggressive disease behavior. Very little is known on the molecular background of the other growth patterns, with one exception. It was found that ill-defined Gleason pattern 4 frequently showed loss of E-cadherin and upregulation of N-cadherin. This pattern might therefore represent prostate cancer undergoing epithelial to mesenchymal transition. Investigation of molecular alterations in growth patterns not only is of scientific interest, but might also have practical impact. At this moment, several molecular tests are available which provide risk classification in intermediate risk prostate cancer and support clinical decision-making. In the development and validation of these commercial tests, information on percentage pattern 4 and cribriform carcinoma was however not taken into account. Few recent publications have compared the outcome of genomic risk classifiers with detailed tissue morphology. And what is interesting is that these studies show that genomic risk classification scores are higher when cribriform pattern is present. Therefore, one might ask the question whether these commercial tests are for a large part not only measuring what we can already see through the microscope, namely as cribriform pattern. The challenge is now to find out what is the real added value of these genomic tests when cribriform pattern and percentage grade 4 are taken into account. I see at least one opportunity for these tests. We all know that the Gleason score at biopsy is a relatively poor predictor of tumor grade at radical prostatectomy, with undergrading in 20 up to 40% of cases, which is due to sampling artifacts. The same is also true for detection of cribriform cancer on biopsy. In about half of cribriform lesions which are present in the prostate, they are missed on a biopsy. So there is a false negative rate of almost 50% for detection of cribriform cancer on a biopsy. Commercial genomic tests could be of added value to identify those cases. Apart from identification of patients with cribriform carcinoma with false negative biopsies, future studies might also elucidate on some other fascinating and clinical relevant subjects. The first is that novel grading schemes could be developed incorporating cribriform carcinoma that could have better discriminative value and be more reproducible. Secondly, studying individual growth patterns instead of Gleason score groups as black boxes will give more comprehensive insight in prostate cancer biology, linking molecular aberrations, pathological growth patterns, and clinical outcome all together. As an example of that the current grading system can be approved, I want to show this figure of a proof of principle study we did. Here we accounted for cribriform carcinoma in the current grade groups. We determined the grade group at biopsy and subtracted 1 point if no cribriform carcinoma was present. As you can see, this led to a significantly better discriminative value for metastasis-free survival and disease-specific death. But please don't start using this system already next Monday. This was just a proof of principle study showing that improvement of current prostate cancer grading is possible, and I think that even better improvement can be reached. To investigate individual prostate cancer growth patterns, we first have to determine what these patterns really are. Over the last 400 years, microscopes have undergone major technological developments. But if you think of it, we are actually still doing the same as Antony van Leeuwenhoek did in the 17th century. We are namely still looking at two-dimensional cross-sections of actually three-dimensional tissue samples and disease processes. In fact, all our histopathological criteria and grading schemes are based on these two-dimensional cross-sections, and we are so used to them that we might simply forget there is a whole three-dimensional world behind them. So, to better understand the individual Gleason growth patterns, we first want to know what they really are in 3 dimensions. I will not go into detail in the methodological steps of studying tissue samples in 3 dimensions. But basically, you can use archival paraffin-embedded prostatectomy specimens, select the pattern of interest, and punch respective area from the block. The specimen of 1 millimeter in diameter is subsequently stained with fluorescently labeled antibodies, chemically cleared, and entirely imaged with confocal laser scanning microscopy. So, in that way, we are, for instance, able to reconstruct this ill-defined Gleason 4 growth pattern. Ooh. That's a pity. I'm sorry, the movie... Yeah. So, what you can see here is a three-dimensional reconstruction of ill-defined Gleason pattern for prostate cancer. It consists of small branching tubuli with frequent mutual interconnections, which give an impression of irregular shaped glands in standard two-dimensional microscopy. As an example, here you can see a normal prostate gland, which is a three-dimensional acinar structure with subtle papillary projections. You can see the basal cells are labeled with keratin 5, depicted as red, and the luminal cells with keratin 18, depicted as green. So what is Gleason pattern 3, consisting of round to oval glands in cross-section? Well, actually, it's a three-dimensional tubular network with sporadic tubular branching and interconnections. We have already seen ill-defined Gleason pattern 4 prostate cancer. It is also composed of a tubular network, but the diameter of the tubules is smaller and the tubules branch and interconnect more frequently. And what about Gleason pattern 5 growing in cords? Well, this is really interesting if you take some time looking at this video. What you can see is that Gleason pattern 5 cords are files of cells, but you can also see that these cords regularly open up to form an intercellular lumen and then close to become cords again. And this raises the question, where do cords end and where does ill-defined Gleason pattern 4 start, as these patterns seem to be continuous in this video. Creepiform pattern looks entirely different. It consists of large snake-like serpentine structures being composed of contiguous epithelial cells with regular lumina between the cells. Characteristic is that the vast majority of tumor cells does not contact surrounding stroma anymore. And this pattern is continuous with solid pattern 5, which has the same overall structure, but lumina are not being formed between the cells anymore. Here again, you can appreciate the continuity of creepiform pattern 4 and solid pattern 5. In the left corner, lumina are present between the tumor cells, being characteristic for creepiform pattern 4, and on the right, these lumina are absent, being typical for solid pattern 5. Summarizing, Gleason pattern 3, ill-defined pattern 4, and cords pattern 5 form a morphological continuum of a tubular network, with a decrease in tubular diameter. And what is fuse pattern 4 then? It also represents a tubular network as Gleason pattern 3, but the tubules branch and interconnect at such close proximity that they appear to be fused on two-dimensional cross-sections. What all these growth patterns have in common is that all tumor cells are still in direct contact with surrounding stroma. This contrasts with creepiform pattern 4 and solid pattern 5, which also form a continuous spectrum, but have in common that most tumor cells do not contact surrounding stroma anymore. So probably these tumor cells have undergone genomic alterations, enabling them to survive and expand without stromal support, reminiscent to so-called anchorage-independent growth and tumor cell culture. Three-dimensional analysis gives us comprehensive insights in what the Gleason patterns really are and how they are mutually related from a morphological point of view. But it also explains a major problem we encounter in everyday pathological practice, and that is inter-observer variability. As pathologists, we might have difficulty in separating crowded Gleason pattern 3 from fused pattern 4, tangentially pattern 3 from ill-defined pattern 4, or ill-defined pattern 4 from cords pattern 5. From a three-dimensional point of view, this is not surprising, because there are no clear cutoff values between these patterns. Gleason pattern 3 tubules might branch, but at which point is the branching that frequent to speak of fused pattern 4? Pattern 3 tubules might also have smaller diameter, But when is it so small to assign an ill-defined pattern for? The good thing is that distinction of growth patterns at the end of their spectra is getting less important. 5 years ago, each patient with biopsy grade group 2 prostate cancer would be operated or radiated. But now in our hospital, and I know also in some hospitals in the US, these men will be eligible for active surveillance as long as they do not have cribriform or intraductal carcinoma at their biopsy. So presence of cribriform growth pattern really starts to influence clinical decision making. And cribriform pattern is one of the most reproducible growth patterns there is. We will never have a problem distinguishing ill-defined pattern 4 or crowded pattern 3 from cribriform carcinoma. In fact, in the next ISUP webinar in December, Theo van der Kwast and Lars Egervat will specifically go into the consensus definition of cribriform pattern and its delineation from its potential mimickers. And that is the end of my presentation. I would like to thank you for your attention, and I'm happy to take any questions.
Thanks, Arno. That was fantastic. We've got one question so far. If anybody else wants to ask some questions, click on the Q&A on your Zoom controls and you should be able to type in questions there and Arno will answer that. We're all very jealous of your 3D images, that's for certain.
Yes, I will read the first question. Do all invasive cribriform pattern 4 have similar prognosis? Is there a difference between small and large cribriform glands? If yes, which criteria to use? Well, that's an excellent question. So since people have studied cribriform growth, they looked at a few things. They looked if you have more small patterns of Gleason pattern 4, so not only one nodule, but maybe 4 or 5, do you have worse prognosis, yes or no? Well, the answer is no. If you have only one single nodule of cribriform cancer, then the outcome was worse. Another thing is the size of one nodule. And there have not been much studies on this issue, but there are really some suggestions that when these nodules are getting larger, so the size of a cribriform field is enlarging, that then the prognosis is really worsening. But what the criterion is, so when it is still small and when it is large, there's no consensus about that, and there are no clinical studies really done on this cutoff size. Yeah. Then another question. Do you expect that image analysis will replace Gleason scoring by a pathologist in the next future? Well, I'm aware of some very good studies on image analysis and Gleason scoring, and they really show that the algorithm that is used has the same level of an expert GU pathologist. So I think it will help us in the future. Personally, I do not think it will replace pathologists. Because, okay, if the algorithm says it is cancer Gleason score 9 and the urologist operates, but the algorithm was wrong and was just inflammation, who's responsible? Is that Philips or is that me? So I think pathologists will always be involved. What I think is that these algorithms might make a selection of, for instance, biopsies that for certain will not have cancer, one certain that have cancer and some that are more doubtful. And that if you see the cancer, you confirm it by eye. And for instance, just run an algorithm on what you see and then get a more objective score of the Gleason score. And does tumor length matter in biopsies? Well, actually it does. And it's quite logical. So the larger quantity of tumor volume you have, that's correlated with a higher volume on prostatectomy samples, and tumor length indeed has prognostic value. It's really interesting. If you look on predictive models for biopsies and in relation to biochemical recurrence after a radical prostatectomy and biopsies in relation to biochemical recurrence after radiation therapy, you can see that tumor length has predictive value of both, but tumor length is more important for predicting biochemical recurrence after radiation therapy. Of course, you can classify tumor length on several ways in a biopsy. You can really measure it, let's say 1.2 millimeters, or you give a percentage of 10%, 20%. Well, we've looked in detail on all these different measurements, and they are all predictive. It seems that really measuring the tumor length is slightly better than giving a percentage, but they are all predictive for clinical outcome. Yeah, then an interesting question, like the most that are here on my screen. How do you approach the cutoff between pattern 3 and ill-defined pattern 4 given two-dimensional sections? Well, that's really difficult. So personally, I use for Gleason pattern 3 that it should be well delineated round to oval glands. If I think that we can still look at tangential sectioning, then I will call it the Gleason pattern 3. So I really have to be sure that the growth pattern behind it is different to call something ill-defined. But this is, of course, very subjective. Actually, as I try to show that, of course, it's subjective, the cutoff between ill-defined pattern 4 and normal Gleason pattern 3. But the three-dimensional reconstructions also show there is no real clear cutoff in 3 dimensions. So Gleason pattern 3 represent tubules that do branch and interconnect, and they get smaller and branch more frequently in ill-defined pattern 4. But there is no real cutoff that, for saying, okay, this is pattern 3 with branching, and this is ill-defined pattern 4 already. This cutoff, it does not really exist in 3 dimensions. So that is why it's very difficult to also find this cutoff in 2 dimensions. The question is it really relevant for clinical management? And in our hospital, urologists do not care that much anymore. If you say we have a grade group 2 patient with 10 or 20% Gleason pattern 4, but not cribriform, they will still think these patients might be eligible for active surveillance. Of course, you should always also take into account PSA values, the number of positive biopsies, MRI findings. But even grade group 2 patients, as long as they don't have cribriform architecture, are still eligible for active surveillance in our hospital. Yeah, it's a very relevant question here. Do you consider glomeruloid structures as cribriform pattern? Well, that's really interesting. So the glomeruloid structures were for the first time described in the ISUP 2014 meeting, and it was decided then to grade them as pattern 4. Of course, morphologically, there is quite some similarities between cribriform pattern and glomeruloid pattern. And some people think or thought that glomeruloid pattern is a precursor of cribriform pattern. That's from morphological resemblance. So if you look on clinical outcome data, there have been a few studies, and that show that if you have a cohort of grade group 2 men, that those with cribriform pattern do worse, but the ones with glomeruloid pattern do better. So that is really counterintuitive if it would be a precursor of cribriform growth. I did not show you this, but we also looked at glomeruloid pattern in 3 dimensions. What happens actually with glomeruloid pattern is the following. You have as base a network, a 3-dimensional network, similar as to Gleason pattern 3. But in this network, specifically at places where tumor glands branch, that's the place where these intraluminal glomeruloid projections occur. But the basic 3-dimensional network is still the three dimensions you can also see in Gleason pattern 3. So I do not consider it as a variant of I do not consider glomeruloid pattern a variant of cribriform cancer. Let's see. Yeah, can you explain the concept of anchorage independent growth? Well, I'm not that deep level of a cell biologist, but I have quite some experience in tumor cell cultures. And you know that if tumor cells, if they can grow within a matrix, for instance, in an agar gel, that when they can survive in such a gel and grow there, that's what they call anchorage independent. And it means these cells do not need stromal interaction anymore for surviving and expansion. But I'm not really an expert in this issue, so I cannot go into that in too much depth. So what do you call cribriform growth with necrosis and presence of basal cell layers? Well, that would be intraductal carcinoma. So if you have cribriform growth with comedonal necrosis and basal cell layer preserved, that means the lesion is within a pre-existing gland and it would be called intraductal carcinoma. Does the percentage of cribriform pattern makes a difference like few glands versus large areas showing cribriform pattern? Well, we already a little bit dealt with that study. As I told you, when you have just several small cribriform areas, it doesn't matter if you have one or have 3 or 4. As soon as you have one cribriform pattern, prognosis is worse. But if you have a pattern, a cribriform pattern, of which the size becomes larger, then prognosis is probably even worse than when you have a small cribriform area. But the exact cutoff has not been defined yet. Yeah, I have a few questions on desmoplastic stromal response. Well, there have been some studies, and mainly from the Cleveland Clinic, that show impressive relation of desmoplastic stromal response with clinical outcome. And it says that if you see desmoplastic stromal response, then the outcome will be worse. Well, I tried to look at it, but I personally found it very difficult to distinguish desmoplastic reaction from normal stroma. And maybe this has to do with the stainings in our lab, but I found it really to reproduce that. But I know there are some studies out there that really show a good correlation, but personally I do not use it, and I have really difficulties in recognizing it. But that's just maybe just due to the H&E sections in our lab. Yeah. Here again, excellent questions. I wondered as to your thoughts as to whether cribriform is truly additive when controlling for grade, stage, margin stages, as we did. Well, the answer is yes. Of course, you can look, for instance, within a Gleason score 7 cohort, and then only look if the ones with cribriform growth do worse or better than the ones without. But the only way to do this in a proper way is to correct for all relevant covariates. So in all the studies I did, and most of the other groups did, is they correct, for instance, on a number of positive biopsies, PSA levels, treatment options, and then relate all those covariates that might be relevant with clinical outcome, and then still cribriform area, presence of cribriform growth stands out. And what is actually very interesting is if you would look at such a model on biopsies in relation to disease-specific death, then typically PSA is a relevant factor, Gleason score is a relevant factor. If you have radical prostatectomy or radiation therapy, it's relevant. Number of positive biopsies and percentage of the tumor within the biopsy. These are normal relevant factors on biopsies. If you start to put cribriform cancer in as a covariate, what happens? The predictive value of the Gleason score really drops down. So you won't see a difference anymore between metastasis-free survival in grade group 2 patients and 1 patient. So this really drops down. And what does this mean? If you look on the occurrence of cribriform growth, you will see it does not occur in Gleason pattern 6 in grade group 1. Then on average about, I think 15 up to 20% of grade group 2 patients will have cribriform growth. That will increase to 60%, 70% maybe in grade group 3 and 80% in grade group 4, and most Gleason scores 9 and 10 will have cribriform growth. So that analysis said that if you put cribriform in the analysis, the predicted value of Gleason score dropped down. And we interpreted that the predicted value of Gleason score is for a large part based on the more frequent occurrence of cribriform cancer in higher Gleason grades. Yeah, it's an interesting question as well. So many interesting questions. Sometimes there are well-defined glands next to cribriform glands, and cytologically they are very alike. You have perhaps performed molecular testing on that type of glands as well. Well, actually, we try to do that. So what is of interest, you know that if you have a case, for instance, of Gleason score 7 with cribriform, and you compare those to cribriform negative Gleason score 7s, then you will see more genomic instability in the ones that have cribriform pattern, specifically more losses of genomes and sometimes amplification of c-MYC. Then the question is really, does this only occur in this cribriform area or also in the surrounding glands? And that's a question I would love to answer, but it's actually quite difficult to study. You really need laser capture microscopy to cut glands out and do separate molecular analysis. But if you really want to do, for instance, RNA sequencing, you need fresh frozen material, lots of sections, so it is really time consuming and labor intensive and very costly. So we did not do that, but that is definitely one of the things we are very much interested in. Okay, this good question. What we are exactly investigating at this moment. What does the 3D analysis tell us about invasion? Are invasive glands continuous with pre-existing glands? Well, that's really interesting. So what has always surprised me that when you look at the radical prostatectomy, you can see loads of cancer, but they seem to appreciate the normal structures. They mostly do not destroy pre-existing glands. So of course you see connections between invasive cancer and high-grade PIN. And that's very difficult to appreciate in two-dimensional sections, but in three-dimensional you can really see that. And that's actually what we are looking at this moment. And not only actually on high-grade PIN transitions to invasive cancer, but even more interesting, the transitions of invasive cancer to intraductal carcinoma. And we get better idea now what is really going on there. But the results we have are a little bit too premature to really expand on that now. But this is really a very good question. It's a very interesting area of research. Yeah, one more. Sometimes fused glands can be problematic and looking like cribriform. Do you have any advice on how to separate them? Well, okay, that's good. And in the study we did on cribriform, Actually, sometimes it was difficult at first to discern whether we're really looking at cribriform pattern or more a complex fused pattern. What is the basic of this is really the three-dimensional areas. Cribriform cancer, the majority of tumor cells do not contact stroma anymore, so they are able to survive and expand without touching the stroma. In fused glands and even in very complex fused glands, if you carefully look, most of the tumor cells still touch stroma, so they need the stroma connection for their survival. So in cases where you are in doubt, is this fused or really cribriform, look whether the tumor cells are still touching the stroma. And this might be difficult sometimes. Of course, you can have some tangential section and you're not sure whether this is really cribriform or might be tangential, but usually in biopsies, we will have 3 or even more levels, and you will be able to appreciate whether this is real cribriform or more tangential section. But the one and only thing that is important to look like, do all the tumor cells still touch the stroma? Or does the majority of tumor cells in a lesion not touch the stroma anymore? And that's really essential. On core biopsies, if cribriform pattern is present, do you always perform cytokeratins to distinguish cribriform from IDCP? Well, personally, I don't. In the first studies on cribriform architecture, we actually did. We were really interested what is more relevant, the presence of intraductal carcinoma or invasive cribiocarcinoma, and we did extensive stainings with immunohistochemistry for research purposes. What we actually found is that they both had added value, for instance, a hazard ratio of about 4 and 5. But if you just added the cribriform architecture, just said there is either invasive or intraductal carcinoma, then hazard ratios went up. So personally, I don't really bother whether it's intraductal carcinoma or whether it's invasive. I just say there is cribriform architecture presence. That means that either within the invasive part or within the intraductal part, tumor cells do not have to touch anymore surrounding stroma or surrounding structures. So personally, I don't really do any effort to distinguish them. Of course, if I can clearly see there is a continuity of cribriform area with pre-existent lens, I would just call it IDCP. But if I'm not sure, I won't do immunohistochemistry. Yeah, what is the rationale for grading each core separately in biopsy? Yeah, of course, when you look at daily practice, when you have 10 biopsies, sometimes you can see that 4 or 5 are positive, and then the Gleason scores are variable between the biopsies. So there might be, for instance, 2 biopsies with a Gleason score 6 and 1 biopsy with a Gleason score 4 + 3 is 7. What should we do? Well, in the latest consensus meeting, it said that if urologists take a biopsy and puts it in separate containers, we will also grade the tumor according to the separate containers. So if you would put in 10 separate containers, you might classify each container separately. Of course, what I always do and advise is just talk to your local clinicians, what they want, what they need, and what is important information for them. I don't believe that very robust and fast recommendations are always practicable everywhere in the world. So that's actually the rationale. So and yeah, this depends a bit per country. So we did some survey last year, actually, or 2 years ago, and that found that more in the US, this was more common sense than, for instance, in Europe. So in the US, there were more people just grading per biopsy, but in Europe, people tended to more to give a global grade. So say on the right, it's a global grade of 3 + 4 6, but not assigning a biopsy grade to each core. But this differs per country, and what is important to really discuss this with your clinics. do you use E-Caterine loss to differentiate pattern 3 from ill-defined pattern 4? No, I do not. When we did the study, we found that some of the ill-defined lesions showed E-Caterine loss and Caterine upregulation, but not really all of them. Personally, I don't really distinguish those because clinically, for our clinicians, they don't really care that much. If I say Gleason score 7 with 10% ill-defined instead of Gleason score 6, these patients are still treated in the same way as long cribiform area is not present. So I don't care and they don't care. So when I'm in doubt, and this happens of course, then I always take the lower side. So if I doubt between ill-defined 4 or tangential pattern 3, I would always choose the pattern 3, as long as cribiform pattern is not present. Yeah, relevant here as well. Are there any evidences that the cribiform pattern does look obvious from MRI methodology? Well, there are several studies looking on sampling artifacts of cribiform pattern in biopsies. And we know now that 50% of cribiform lesions, more or less, are missed on a biopsy. So it is present in a radical prostatectomy, but was not present in a biopsy. That's 50%. Of course, you want to identify those men that have potentially aggressive cribiform lesions within the prostate. What can you do then? Well, several studies have looked at MRI, and actually this did not turn out to be a very strong, it doesn't have really a very strong MRI correlate this cribiform areas. So they were not really able to identify it. We did a study as well, and we found that if you have a Pirate score 5 tumor and a cribiform negative Gleason score 7 biopsy, then you more frequently saw a cribiform pattern in radical prostatectomy specimens. So Pirates 5 might help, but I think again the results were a little bit too immature to really draw strong conclusions on that.
I think we're going to draw that to a close, Arno. You've done very well. The questions
I don't know what the time is.
It's past 8 o'clock, and the questions are increasing at a faster and faster rate, and you can't clear it all up. So his email address is on the on the last slide. So if anyone has any more questions, burning questions, I mean, hundreds of questions spring to mind as you show us all this information that we've always thought about, but not really had the time to think about it. So any more questions you can send to Arno on his email address. You can see on the page there. But, thank you very much, Arno. That has been absolutely brilliant.
Thank you very much. Thank you.